Hi, and welcome to Health Plans Save when members switch, going beyond generics for healthcare savings. We are thrilled to introduce ConnectureDRX's new therapeutic interchange technology called DatabaseRX. Today, we are going to address real-world healthcare risks affecting all of us and discuss solutions for each of these risks in order to help build health plan and member resiliency. Resiliency is the ability to recover quickly from hardship. And in a world full of unforeseen difficulties this year, to put it mildly, we want to focus on key solutions stemming from a powerful technology called therapeutic interchange. We are excited to be with you today to present important information about how using therapeutic interchange can not only lower medication costs, but significantly lower overall healthcare costs. We'll discuss how it can improve member engagement and elevate customer satisfaction, and how your members can proactively control their medication spend with significant cost savings for your health plan and much more. I'm Amanda Woodman, Sales Executive with ConnectureDRX, and I'm here today with Arthur Tu, our Director of Product Management, and Janie Kim, Director of Clinical Services of ConnectureDRX. Their story and experience in this space will open up new doors for you as we share the impact of this exciting technology. So today we'll give you a brief overview of ConnectureDRX and talk about what therapeutic interchange technology is and why experience and expertise in the pricing of drugs matters so much in the Medicare space. Then we will show you how DatabaseRX tackles 5 real-world healthcare issues by demonstrating use cases and the supporting data. We'll wrap up the session by showing how DatabaseRX is an important tool in building resiliency and improving relationships with your partners and members during these uncertain times. A few housekeeping items before we get started. The session is about 40 minutes, so we will have time for a Q&A at the end. Please type your question into the questions box on your panel. We will send a follow-up email with the recording along with any questions that we don't get around to today. So about ConnectureDRX. ConnectureDRX has been around since 2000, and many of you might know us better as DestinationRx. DestinationRx became Connecture in 2013 with a focus on the under 65 market. And then in 2019, we shifted back to a sole focus on Medicare and added DRX back to our brand, so we are now known as ConnectureDRX. We were purchased by Harris Computer Systems in 2019, which has been a really positive move for us in helping us develop our technology and expand our presence in the market. We are the market leaders in Medicare shopping, quoting, enrollment, and retention. And as a software company, we develop innovative solutions for health plans, provider-sponsored health plans, and FMOs, all with the goal of providing beneficiaries with their best fit Medicare plans and medications. We also provide network distribution for our customers in order to connect our health plan customers with the largest number of agencies and agents as possible, ensuring the most plan visibility. We boast the largest Medicare distribution network in the industry because of the value it brings to our customers. ConnectureDRX has a long history of expertise in the Medicare Part D pricing space. We currently provide drug pricing and transparency services to 95% of the Medicare Part D market. And to that end, we wanted to share that our extensive experience in drug pricing gives us a leg up in understanding how health plans need to respond in the market today. We talk about our gold standard pricing in the Medicare industry because it is the most accurate in the industry. And there's several reasons for this. One, we gather the most data directly from carriers, utilizing the same data they send to CMS for the Medicare.gov cost calculations. Two, our tools can price drugs down to the local pharmacy level. Three, our cost calculations take into account the most factors, including partial gaps, donut hole, preferred status, subsidy, and discount variances. And four, we also update our drug pricing data every 2 weeks. This information is important to setting the stage with what is going on in the world today as we look at the extraordinary cost of prescription medication and the ability for health plans to find the most effective lower cost options for members. all with the goal of improving outcomes and lowering overall healthcare costs as members keep money in their own pockets. We know that if health plans can assist members in this way, members will have higher levels of customer satisfaction, which will prevent plan switching and improve member loyalty. Therapeutic interchange is a powerful solution to real-world healthcare problems. It is a technology that you may not be too familiar with, so we want to share its power via data and case studies to demonstrate why it's so effective for health plans in lowering the overall healthcare costs, along with a multitude of other benefits. So we're going to discuss why it's important to go beyond just changing from brand name drugs to generics, how therapeutic interchange offers solutions in the face of drug shortages and recalls, the magnitude of potential savings using a real-world case study, how price transparency impacts prescribers and pharmacists and puts members more directly in control of their own health, and finally, how therapeutic interchange helps members improve medication adherence, which can ultimately improve health plan star ratings. Each of these areas has the power to better connect health plans to members, elevating electronic engagement, increasing member satisfaction, and ultimately building trust and brand loyalty. So I'm going to turn the presentation over to Janie, and we'll dive into the power of therapeutic interchange.
Thanks, Amanda, and hello, everyone. Thank you so much for joining us today. Before we get to the real-world examples, I wanted to start by describing what therapeutic interchange is. According to the Academy of Managed Care Pharmacy, therapeutic interchange is defined as the practice of replacing, with the prescribing physician's approval, a prescription medication originally prescribed for a patient with a chemically different medication. In other words, it's when you take one drug and replace it with another drug that is comparable in its effectiveness. The power of therapeutic interchange can be incorporated into a member or prescriber-facing tool, an analytics engine, or a drug database to identify cost-saving strategies for health plans and members through the use of lower-cost drug options. It goes beyond replacing high-cost prescription medications with generic equivalents and can incorporate other comparable brand, generic, and over-the-counter medications. All therapeutic interchange programs should be evidence-based, meaning the rationale behind the program should be based on clinical effectiveness research and other medical literature. This is important because there's usually more than one drug available to treat a particular condition. However, clinical evidence can further delineate and show which drugs can be interchanged for each other and under what circumstances it would be appropriate. This is why extensive and ongoing research is necessary and vital. At ConnectureDRX, we have one of the most comprehensive therapeutic interchange databases used by health plans and PBMs for over 20 years. You can see here the different types of references that can be used during the development process. DatabaseRX was created using all of these sources, including clinical studies, practice guidelines, as well as drug information sites and manufacturers' prescribing information. We also look at product recalls and the reasons behind them, whether they originate from the manufacturer or the FDA. We also use data from drug data warehouses like Medispan and FDB. Currently, DatabaseRX has over 140 drug classes with over 42,000 active NDCs. To illustrate the evidence-based research that is involved, I'll take a few minutes to share with you an overview of the process we use here at ConnectureDRX so you have a better understanding of why this is so valuable, and also to give you an idea of the enormity of work required to create a comprehensive database. All therapeutic classes are created and maintained by pharmacists. Our pharmacists review a large number of medical literature to identify which drugs and at what doses can be interchanged for different conditions. Then, board-certified physicians who are all practicing in their respective settings review what has been created to ensure it's consistent with current practice trends and what they're seeing with their patients. After physician review, drug classes go through a database integration process. This is where the clinical research is merged and integrated with drug data elements such as NDC and package sizes to include into the database itself. Maintenance is the final step, and it's actually the most arduous step in the process. We have to ensure that all of the therapeutic interchange drug classes that have already been created are continuously kept up to date with new drug approvals and discontinuations, as well as new practice guidelines, clinical studies, and safety notices. Now that I've given you a quick background of what therapeutic interchange is and how ConnectureDRX develops and maintains our database, I'll turn the presentation over to Arthur to discuss ways health plans can use therapeutic interchange to go beyond generics.
Thanks, Janie, and hello, everyone. I'd like to start by briefly explaining the different types of therapeutic interchange options. The first are direct generics. A direct generic is a drug that's identical to the original brand drug in chemical composition and thus does not require a new prescription to make the switch. For example, Lipitor and atorvastatin have the same chemical composition, so a pharmacist can switch a member from the brand to the generic without needing to consult with a prescriber. Second are generic drug alternatives. These are lower cost medications that are generics but cannot be switched automatically. The prescriber must write a new prescription to authorize the switch. Third, we have preferred brands, which is a comparable brand drug and not a generic. These also require a new prescription from the physician. Finally, we have over-the-counter medications. Members can go from a prescribed drug to an OTC comparable option, removing the need for a new prescription. Often, members or prescribers are unaware that an OTC is available. This is typically a more cost-effective option. One of the reasons we are talking about going beyond generics is because switching to the direct generic does not always have the best savings potential. To show you how this can be the case, ConnectureDRX took a look at the formulary reference file maintained by CMS. This is a list of roughly 6,000 drugs available for Part D programs. Out of the 6,000 drugs, there are roughly 3,200 brands. Per the graph, of those 3,200 brands, 62% had a therapeutic interchange option. This compares to only 40% which had a direct generic option. That's over 700 additional doses in the therapeutic interchange database, presenting a wealth of opportunity going beyond just generics. To further illustrate this point, let's look at two examples where the direct generic is not the cheapest option available. Here, we have averaged out the cost per unit for different branded generic drugs using CMS retail pharmacy pricing. These costs represent what health plans are paying for these medications, a portion of which is then passed on to their members as co-pays or coinsurance. The average Medicare cost of EpiPen is $310 per unit. Its direct generic, epinephrine, is $161, a 20% savings. However, there's also a brand alternative called Syngepi at $133, a savings of over 57% off the brand. For another example, let's look at the ADHD drug Concerta, retailing at $390 per month for 30 tablets. The generic methylphenidate is $179 for a comparable dosage, a savings of 54%. Sounds great, but there is also a therapeutic interchange option of generic Adderall, requiring 60 tablets a month, but costing only $38 per month at this quantity. That is a savings of over 90% off the original brand Concerta. These examples show how important visibility into therapeutic interchange options can be for health plans and their members. In switching from Concerta to generic Adderall, there is over $350 per month in savings, a significant cost reduction over time. In total, when looking at the over 6,000 medications on the CMS FRF, we determined that roughly half had potential lower cost alternatives in the market. A little later on, we will look at a case study of the magnitude of potential savings. But first, I'm going to turn it back over to Janie to discuss our next real-world scenario.
Thanks, Arthur. Now I want to show you an example of how therapeutic interchange can be used in the setting of drug shortages and recalls. In April of this year, the FDA announced an immediate market withdrawal of all ranitidine drugs, more commonly known as Zantac, due to reported carcinogen contamination with NDMA. This was following months of voluntary recalls after trace amounts of the carcinogen were first reported in 2019. This recall affected millions of individuals who were taking the OTC drug, along with the 15 million people on prescription Zantac. Health plan members with access to a drug comparison or therapeutic interchange tool would be able to log on from any device and look for other options for Zantac. This puts the power into the hands of the member, who now armed with new information, can be proactive with their own health and take the initiative to talk to their physician or pharmacist about other alternatives. In our current situation of social distancing and avoidance of in-person settings, people might be afraid to walk into a pharmacy. In looking at an OTC product such as Zantac, members can identify the options, order the drug online, and even pick the medicine up through a pharmacy drive-through or have it shipped directly to their home. Some of the therapeutic interchange options for Zantac include Tagamet, Pepcid, and Axid. Interestingly, the Zantac shortage has led to people taking more Pepcid or its generic famotidine. And as a result, famotidine has been added to the list of drug shortages by the FDA as well. As you can see, the world of therapeutic interchange is ever evolving and must stay current to support the needs of patients, prescribers, pharmacies, and health plans. As a result of COVID-19, drug shortages are top of mind these days. It's creating a paradigm shift, helping pharmacists to become more resilient than ever. Pharmacists can send requests to prescribers and let them know a medication is out of stock and initiate a change for a different therapeutic drug option. And now, new laws in certain states allow pharmacists to dispense other drug options without requiring a new prescription. A therapeutic interchange tool can empower pharmacists to navigate the member's formulary along with drug pricing information, enabling them to be more proactive with finding new drug options for their patients than ever before. Now I'll turn it back to Arthur to discuss another real-world example.
Our next real-world situation focuses on high prescription costs and how to lower them. COVID-19 has dramatically changed healthcare delivery, and the economic impact of the virus on healthcare spending is still not fully known. The prices of almost 500 prescription drugs have risen this year, with an average increase of 5%. These prices started going up in January when the first cases of COVID-19 occurred in the United States and have not stopped. The graph on the right shows you the average price increases for the top 10 brand name drugs over the past dozen years, as compared to the overall inflation rate, according to the Bureau of Labor Statistics. According to JAMA, prescription drug prices rose 3 times faster than inflation over the last decade, even when discounts were taken into consideration. According to a recent Truven Health Analytics NPR Health poll, 67% of patients do not take their medications because they cannot afford them. Due to the economic impact of the pandemic, unemployment peaked in April at 14.7% and currently sits at a little over 10%. These are the highest levels since the Great Depression, even higher than the Great Recession about a decade ago. With rising drug prices and decreased consumer spending, we can anticipate that medication adherence is going to become more and more of an issue as people cannot afford their medications. This means lower cost therapeutic interchange options are going to be more important than ever in this difficult landscape. So now let's look beyond generic to see the potential magnitude of savings we are talking about. We ran an opportunity analysis on over 8.7 million prescriptions for CMS FRF drugs over the past year. We put this claim data through our analytics engine and evaluated the estimated cost and potential savings amounts by therapeutic class. The potential savings here are available to health plans as members switch from higher cost to lower cost drugs. The 8.7 million prescriptions added up to about $1.2 billion in overall spending. Of these, roughly 32% had lower cost options in our database. If all these prescriptions were switched to lowest cost options, the savings would be 37% of the original overall spending, a savings of $219 million. If even just a fraction of these beneficiaries can be changed to lower cost drug options, the potential savings is significant. Digging a little farther, we can see that roughly 2/3 of the savings are made up by the following 10 categories. There's a lot of information here, but I want to just drill down into 2 specific examples that help make up these numbers. First, let's look at diabetes. As we know, diabetes is a big problem in this country. Over 34 million people in the United States suffer from this condition. Insulin prices, meanwhile, continue to go up and have tripled in the past 10 years. Looking more closely at the category, we have one example, Novolog, of which 550,000 units were prescribed in our case study at $30 per unit. A comparable brand is Admelog, which comes in at an average of $13 per unit. If our case study health plan is able to get all their members to switch from Novolog to Admelog, they would see a savings of over $9.3 million in retail costs a year. Here, we can see the potential power of how a simple $17 per unit savings can add up quickly when matched with a commonly prescribed drug. Now let's look at rheumatoid arthritis. Rheumatoid arthritis is a costly condition requiring consistent aggressive treatment for many years to control symptoms, manage pain, and stop disease progression. Rheumatoid arthritis is estimated to cost $19 billion a year in the United States, with many patients paying up to $30,000 annually for their medication costs alone. Those with insurance can still end up paying 30% or more of the total cost of certain medications. If we look at the specific drugs in the rheumatoid arthritis category, we can see the following. Humira was prescribed in our claim study about 21,000 times at an average cost per unit of $2,600. We're comparing Humira to other drugs in the rheumatoid arthritis category, and taking into account efficacy, we find that Cimzia, which, while costing $4,400 per unit, requires half the dosing of Humira. This means that switching all 21,000 units of Humira to Cimzia resulted in a savings of over $8.4 million in our case study. This highlights the importance of having accurate dose-to-dose ratio information, since Cimzia, while costing more per unit than Humira, is still more cost-effective since members would be taking less of it. Finally, we did a breakdown of what type of switches were most common and beneficial in our case study. In looking at the chart below, we can see that switching members from a brand to a generic or from a brand to a lower cost brand gave us the greatest cost savings potential at over $70 million for each category. Going from generic to another generic had over $48 million in potential savings, largely due to the high volume of units prescribed for these lower cost drugs. Finally, it is only a few instances where the direct generic was the lowest cost option, and these accounted for roughly $17 million in potential savings. In summary, we can see how much power there is to make a difference in the financial outcomes of both members and health plans by bringing therapeutic interchange analytics into play. And while individual results will vary based on a health plan's own negotiated pricing and preferred drugs list, the overall process and magnitude of the potential savings should remain consistent. Next, let's talk about ways we can try to realize that savings potential by using the therapeutic interchange system to bring greater price transparency on drug costs and comparable treatments on the healthcare market. Now we move on to our fourth topic and how price transparency can help us realize our savings potential. People generally don't pick the lowest cost drug simply because they do not know what their options are. From prescriber to pharmacist to member to health plan, price transparency around medications and their alternatives continues to be a gap we face in the healthcare market. Let's take a look at some potential points of interaction where we can introduce therapeutic interchange technology to make a difference. First, we will start with the prescriber. Being at the front of the prescription chain, the doctor's office is the ideal place to introduce price transparency and to put the member on the right fit prescription. This helps patients from having to do costly callbacks to the doctor, saving everyone time and money. With the increasing adoption of e-prescribing and electronic health records in physician offices, there's never been a better time to get therapeutic interchange options into the hands of the provider. Being able to see the estimated cost for the prescribed medication along with a list of potential options would be hugely beneficial for physicians, as it would save them time from costly callbacks and help improve their patients' adherence to the prescribed regimen. As healthcare integration continues to advance and prescribers become ever more aware of savings opportunities for their patients, having price transparency to therapeutic interchange options will become more and more critical to the daily operations of the doctor's office. While real-time integration with existing e-prescribing and EHR systems would be ideal, due to the complexity of systems involved, this could be a time-consuming process, slowing down adoption. In lieu of that integration, standalone sites can help bridge the gap, getting physicians the information they need from a reliable source. ConnectureDRX's Drug Compare Suite is an example of such a source, providing cost transparency and therapeutic interchange data to a multitude of users. On the slide, you can see a screenshot of one instance of the Drug Compare tool. This technology can be used as a hosted site or made available via API and interface with the electronic tools doctors are using today. It is a great way for prescribers and members to confirm that the prescriptions they are starting on are the right fit medications for their plan. The next step in the prescription chain are the pharmacists. Price transparency helps empower pharmacists to be proactive care providers. They can help research pricing for members and be a bridge between the member and the physician. They are also the first to know when a member is trying to purchase a drug that is high cost or off formulary. But how do we get the therapeutic interchange data into the pharmacies? Many PBMs today accept preferred alternative drug lists from health plans. These are lists of high-cost target drugs and the preferred alternatives specific to the carrier's formulary designs. When a pharmacist tries to adjudicate one of these target drugs for a member, the pharmacist system can return the list of alternatives for them to recommend to that member. The pharmacist can then take this information to the prescriber and get that prescription changed before the patient starts on their medication. With the therapeutic interchange system, ConnectureDRX can take in a health plan's formulary and pricing data and use it to generate these preferred alternative files for PBMs in their specified format. We can consider the prior authorization restrictions in prioritizing the options to reduce unnecessary overhead, fewer calls and faxes. We can turn these files back over to the health plan's clinical team for review, quickly delivering thousands of lower cost options tailored to the plan's specific formulary. Finally, we can update these files regularly as new drugs appear and old drugs leave the market, saving clinical teams time and effort that can be used on other initiatives. In-pharmacy messaging is an excellent option for health plans looking to provide options for their members struggling with the sticker shock of high-cost medications. Big data analytics continues to be an emerging technology in the healthcare space. While information is becoming more electronic, the tools for extracting, transforming, and interpreting that information lags in healthcare due to fragmented internal systems often acting in silos. Data security and HIPAA compliance rules, while critical for safeguarding personal health information, also presents a significant barrier in getting data science initiatives off the ground. The analytics engine powering the previous case study, or opportunity analysis, is an excellent tool for giving health plans visibility into their members' drug utilization and therapeutic interchange opportunities. It runs off de-identified claims data, so no personal health information needs to be exchanged. For Part D plans, the analytics uses the same formulary and pricing information carriers already submit to CMS, or in many cases, already submit to ConnectureDRX for our plan shopping tools. If no plan pricing is available, the analysis can utilize cost information derived from the claims data itself to build pricing models for therapeutic interchange comparison. The result is a detailed report highlighting key classes and medications that the health plan can target to receive the greatest savings on their investment. Once armed with the opportunity analysis data, health plans can then begin outreach programs to the members identified to be on high-cost medications. These outreach programs can communicate via email or text message or direct mail to inform members of how they can reduce the cost of their prescriptions with comparable efficacy. These communications can then encourage members to speak to their physicians about the alternatives listed or direct them to do research on a site like Drug Compare so they are fully aware of their options. While getting individuals to switch prescriptions can be a difficult process, if even a small portion of the targeted members make the switch, the savings, as we saw in the previous case study, can be substantial. Given the rising cost of medications and the current economic climate, presenting members with hundreds or potentially thousands of dollars in savings can be a key differentiator in medication adherence and member-carrier relationships. And now let me pass it over to Janie, who will talk more about the importance of medication adherence and take us through star ratings.
Thanks, Arthur. To end our webinar today, let's take a look at how therapeutic interchange can affect star ratings for health plans. Therapeutic interchange offers medication options that can significantly reduce costs and improve adherence to prescribed treatment regimens. A 2019 Kaiser Family Foundation report showed that many seniors stated having difficulties affording their medications and taking them as prescribed, and nearly 80% stated their condition worsened due to not taking their meds. The cost of medications has been shown to be one of the biggest barriers to adherence, if not the biggest. As studies have concluded time and time again, when drug costs less, members are more apt to follow their prescribed treatments, which leads to better health outcomes. And as we all know, unfilled prescriptions can lead to an increased risk of patients going to the ER, along with the chance of costly hospital readmissions. So adherence to medications is very important because it shows a positive correlation to improved health outcomes. This importance is even reflected in CMS's star ratings. Out of the maximum 47 measures for 2020, 18 of them were related to medication management and adherence. In addition to this, there are 4 measures that are triple weighted. These are for diabetes, high blood pressure, high cholesterol, and SUPD, which is short for statin use in persons with diabetes. If you count these triple weighted measures, then nearly 50% of the star rating measures relate to medication adherence. So why is this relevant? Navigant Health conducted a study in 2018 which showed MA plans that were able to improve their star rating from 3 to 4 stars can see revenue increases of 13 to over 17% through increased enrollment revenue and additional QBP bonus payments. In determining star ratings, as stated before, medication-related measures influence 37.5 out of 75 star rating points, or 50% of the health plan's performance. The ability to improve star ratings can also impact the financial incentives a health plan can receive. One of the best ways to increase star ratings is to address medication adherence. MA plans that currently are rated 4 and 5 stars receive an approximate $500 per member per year from CMS, which for a 10,000 member plan can equate to $5 million or $25 million for a 50,000 member plan. According to CMS in 2020, approximately 48% of MAPDs were still rated with less than 4 stars and not yet eligible for these incentives. By focusing efforts on these medication adherence measures, MAPD plans can maintain or increase their star ratings, which not only translates to healthier outcomes for their members, but also provides additional financial incentives to the plan as well. DatabaseRX combined with our repository of prescription drug costs can be used to help identify members eligible for MTM programs, as well as provide a tool for healthcare professionals to proactively engage members and employ interventions related to these star measures. And now back to Amanda to wrap things up. Amanda?
In these uncertain times, one thing will remain consistent, and that is your Medicare members will continue to look to you for guidance and assurance when it comes to their health and wellness. Therapeutic interchange is an approach which provides this assurance through lowering costs and improving adherence and outcomes. Going beyond generics and gaining visibility with a tool to engage at multiple points in the prescription lifecycle is key in building resiliency and a healthy member population. At the end of the day, building resiliency between health plans and members in these uncertain times is about finding not only the best fit Medicare or health plan, but also finding the best fit medications for members. In each of these areas we addressed today, going beyond generics, addressing drug shortages head-on with therapeutic options, lowering drug costs, viewing these lower cost options earlier in the prescribing process, and improving medication adherence will all support health plans in improving their star ratings. Before we wrap up, I'd like to share some information about our Plan Compare One tool that many of your members and agents will be using this year with AEP up and coming. For those of you not as familiar with our digital Medicare technology, here are some quick highlights. Plan Compare One is one platform for all audiences for the purpose of shopping, quoting, and enrollment. It is also the platform for our Medicare retention solution, where you can get ahead of protecting your customers and keeping them with you year over year. Plan Compare One has a responsive design across all devices, including laptop, tablet, and phone, which makes telework very easy. And the platform is highly configurable with both hosted and API options. The guided decision support within Plan Compare One offers the ability to personalize the experience for beneficiaries by providing a total out-of-pocket cost calculation when adding information like health status, age range, prescriptions, subsidy, and pharmacy, all with the goal of increasing self-service enrollments. This AEP, we are offering new features, including text to enroll, text to complete a scope of appointment, and blue button integration, among others. At the end of the day, we want to make sure beneficiaries are paired with their best fit plans, decision support based on the most accurate drug pricing in the industry, and out-of-pocket cost estimates goes a long way in elevating member satisfaction and keeping beneficiaries with your brand. And finally, just a word about the importance of the right network and using your distribution channels optimally. There are opportunities you don't want to miss out on to increase your connection to your customers and increase enrollments. For direct consumer, self-service enrollments are rising. Last year, Deaf Research showed more than 20% of switchers change plans directly through online channels. Our technology will encourage and guide seniors to self-serve with an experience that will foster confidence and prevent plan switching in the future. Call centers can become overwhelmed with seniors who want to be reassured about their plans. Data preloading of demographics and drug lists is a highly efficient way for call center agents to expedite calls and reduce handling times. And lastly, agents in the field can maintain their book of business quickly and accurately with access to drug and plan information and the multiple methods for quoting and enrollment. This allows for a positive experience for each beneficiary, all while reducing the time it takes to enroll. Thank you for joining us today. We also invite you to visit our website at ConnectureDRX to learn more. We welcome your questions at this time. For questions we don't get to today, or if you think of any after the webinar, please contact us at marketing@connecture.com and we'll follow up with you after. So we're getting some questions in. I'll take the first question. The first question is, what have you done technology-wise to open distribution in a COVID world? Well, with face-to-face no longer being a safe option, at Connecture, we've worked very quickly to introduce new teleworking features. So the first of those being text to scope and then text to enroll. So really what that is it allows agents and their beneficiaries to complete those tasks via text message if the beneficiary does not have an email address, which is super helpful. And then the second feature is the sign and submit. This allows agents to assist with the enrollment process and then send the form via email for the beneficiary to provide their attestation and signature. And not to leave out the quick quote, although it's been a staple in our feature set for quite some time, with the new enhancements we've made, it will be a very highly utilized feature during this time as well. We have another question. Can you explain more about the pricing you used in the opportunity analysis case study? And we'll give this one to Arthur.
Yeah, sure. ConnectureDRX, we receive pricing data from the vast majority of Medicare Advantage carriers as part of our hosted sites and our BrokerLink network. This data breaks down the unit cost for each drug at each pharmacy across the United States. We took this information and then we merged it with the CMS public use file data to build a matrix of the average drug cost by region. And then we plugged it in those values into our analysis. So we can say what the average drug cost for a particular NDC is in a particular state. Now, if we were to do target opportunity analysis for someone, we wouldn't have to use that aggregated data. We would use your own plan-specific pricing, or we would take sample pricing calculated from the claims data to do those comparisons. So generally, there's a lot of options available, and it just kind of depends on what's easiest for you to provide.
Thanks, Arthur. Looks like we've got a good one for Janie. Why would I need DatabaseRX? Or in addition to what I currently do, how is data different than any other PBM?
Oh, so that's a good question. So first off, our therapeutic interchange database is actually used by various PBMs in their programs. And in fact, DatabaseRX is actually designed to work in conjunction with data from the PBM. And I think the easiest way to explain DatabaseRX is to say that it's really composed of two main parts. The first is the therapeutic interchange database portion, which is the clinical part, and then the analytics engine. So when we look at the therapeutic interchange data, I think that's going to be one of our biggest differentiators, as our database is comprised of those dose-to-dose comparisons, which is ideal not only when you're speaking from a clinical perspective, but also when you're trying to really determine the cost of medications. And the second part, which we have the analytics engine that can take in different forms of information like full claim sets, aggregated claims data, formulary data, and the like, and merge this with the clinical interchange data to be used in a variety of different cost savings or drug optimization programs. As a health plan with DatabaseRX analytics, you can proactively identify your members who could potentially see high savings and then create, outreach programs to them tailored to your needs.
Great. Okay, and I think we've got one more question here. I think we'll give this one to Arthur. Given that medication adherence is critical to plan performance improvement and star ratings, can you reiterate the opportunity for how that would work?
Yeah, sure. Like Jamie mentioned, studies have shown time and again that drug costs are a key factor in whether members adhere to their drug regimens. I mean, it's pretty basic. If people can afford their medications, they're more likely to buy their medications. So in our previous example of a member switching from Concerta to generic Adderall, that member was going from $390 per month to about $38. I mean, that's a significant savings for the average consumer. And then if you're looking beyond just the retail costs, you also have scenarios where you're moving members from kind of $100 copay down to $15 or less copays for generic drugs. So we believe that if members have that kind of price transparency around their drug costs, they're going to be more likely to stay on their medications if they know that they're buying the best priced drug for their condition.
Thank you, Arthur. Thank you, everyone, for joining today. We hope you found this session valuable. And we will have the recording available to you very shortly.